Everyone for joining us for the December version of the JVS Journal Club. We are really excited to have two great sites with us tonight that are sponsoring the JVS Journal Club, which is LSU and Thomas Jefferson University. The articles that we will be going over, also all the authors or the major authors are here to be able to discuss this with us. So that's really exciting for us too. The first article we'll be talking about are outcomes of bypass and endovascular interventions for advanced femoral popliteal disease in patients with premature peripheral artery disease. Dr. Tanner Kim and Dr. Cassius Char are here with us today. And then we will also be looking at pre and postoperative predictors of clinical outcomes of fenestrated and branch endovascular repair for complex abdominal and thoraco-abdominal aortic aneurysms in an Italian multi-center registry. And Dr. Fagioli, as well as, Enrico, I didn't know your last name, sorry, are with us this evening. So from LSU, we have Dr. Mal Sheehan, who is our faculty member who will be discussing or introducing his article along with Dr. Katie Swanson, who is their fourth year integrated resident. And from Thomas Jefferson University, Dr. Babak Abai, who has been, I'm pretty sure, attended every single journal club that we've done, even before we made it formal, whenever they were doing it in the less informal way. And his resident, or his fellow, sorry, Dr. Ali Reza Mafid. From the papers that we will be discussing, again, from Yale School of Medicine, the senior author, Dr. Char, and his resident, Dr. Tanner Kim, who will be able to answer questions from their manuscript and really help us dive into the nuances of that work. And then, of course, from the University of Bologna, Dr. Fagioli and Dr. Galido will be joining us as well. Thank you for getting up at this god-awful time to be here with us. We really do appreciate it. We have two special discussants, Dr. Kelly Brown, who is the Chief of Vascular Surgery at the VA Medical Center and at the Medical College of Wisconsin. And then Dr. Michael Stoner, who is Professor in Chief of Vascular Surgery at the University of Rochester. Just a few little housekeeping items. Please stay muted. If you have questions, please put them in the chat. Our discussion leaders, Dr. Brown and Dr. Stoner, will kind of bring those up. And of course, the event is being recorded for on-demand access, and you can watch this again later as needed or for your trainees. The next year for 2022, we've had the sign out go out to all the vascular program directors. We've had great turnout. Almost every month is already filled. And our first month in January is being sponsored by the University of Michigan, Dr. Don Coleman, and Dartmouth Hitchcock University, Dr. David Stone. So you can look for that information after coming out in January. So I'll stop sharing my screen and we'll turn it over, I believe, to Dr. Sheehan.
Thanks, Misty. Let's see if I can manage this. So if you opened up Rutherford Volume 1, I don't even know if it was called Volume 1, but if you open up like an early version of Rutherford and you looked at premature PAD, you probably wouldn't find much, because we used to think that peripheral vascular disease in young people wasn't really atherosclerotic. It was categorized more as an arteritis like Berger's disease or a developmental anomaly, or like FMD. So it's only over the past 30 or 40 years that we've started to realize that this atherosclerotic process can even happen in younger people. This study from the University of South Carolina looked at a group of people between 1985 and 1990, and they started to find some commonalities in people who present young with premature atherosclerotic disease. So they defined it, and this is something you'll see in a lot of the studies, is they define it differently. So here we're defining it people younger than 40 years. But again, they start to see that these patients have worse outcomes. And in addition, they start to see that they have a lot of reintervention. So if you operate on people who are young, you can expect to have to do it over and over again. And 53% of their young patients had to have a second procedure, and most of them were in the first year after the initial procedure. This is a paper I actually forgot that we wrote during my fellowship at BI Deaconess. I think the authors of the paper we're reviewing today forgot it as well because they didn't reference it. But I'm just joking to the Yale guys, just jokes. But anyway, at this study that we did at BI Deaconess, we looked again at patients younger than 40, and we identified 51 of them. And so some of the things we found is this is very rare. So during this study period, over 4,000 bypasses were performed at BI Deaconess, but less than 2% of them were in people younger than 40 years of age. We also found what other studies will confirm is the outcomes are worse. So the 30-day graft failure is 11%, and the 1-year mortality is 12%, which is very high since the average age of the cohort was 36 years old. We also found that renal failure was the #1 predictor of mortality early in these patients. And this study from Wake Forest, they moved the age up to 55 years old, which I like better at my age. So now we're calling people young who are less than 55. Average age of this group was 49. And again, survival is pretty poor for a cohort of 49-year-olds. So 84% 5-year survival. So people who present with PAD early have a lot of reinterventions, and they tend to die younger. And finally, this study from UT Southwest was a prospective longitudinal study of 51 white men who presented with symptomatic PAD before the age of 45. And what they found is that these patients, again, they tend to die fairly young, and they tend to need a lot of reinterventions. And very few of them actually could be left alone. Most of them had at least one intervention over the cohort study period. And the biggest group was those that required multiple interventions. So again, a lot unknown about this age group, but there is some commonalities that we can see in the literature. So with that, I'm going to hand this over to Dr. Swanson, our 4th-year resident, who's going to review the article.
So before that, Dr. Sheehan, this is what the first edition of Rutherford looks like. It's called Vascular Surgery. There is a 7-page chapter on thrombotic arterial occlusions, and that's it, about peripheral artery disease. And it was written by Tom Fogarty. So.
Perfect. Glad I wasn't called out for lying yet on this.
Thank you, Dr. Sheehan, for that introduction. I would also like to thank those involved in planning this event for the opportunity to present this article. My name is Katie Swanson. I am one of the 4th-year integrated residents at LSU. I'm going to be presenting the paper Outcomes of Bypass and Endovascular Interventions for Advanced Femoropopliteal Disease in Patients with Premature Peripheral Artery Disease. This is a study out of Yale University whose authors are here tonight to further discuss the paper. It was published in the December issue of the Journal of Vascular Surgery. Premature PAD is defined as PAD which presents at age less than 50 years. This is often due to genetics, high rates of smoking, diabetes, and renal disease. We know that these patients often have high rates of atherosclerosis and other arterial beds, and for a combination of reasons, the perioperative and long-term outcomes amongst this patient population has been poor. Vascular surgeons have tried to find the best way to help these patients and develop some kind of revascularization treatment algorithm based on the extent of the vascular disease present. There are multiple classification systems that vascular surgeons use to classify PAD. One of the most widely used is the TASC classification, which was utilized by the authors in this study. It's widely accepted that endovascular intervention is durable for TASC A and B lesions, but the best revascularization strategy for TASC C and D lesions, more advanced disease, has remained controversial. So the authors sought further answers on this topic. They aimed to compare the outcomes of patients with premature PAD who underwent open bypass to those who underwent endovascular intervention for advanced femoropopliteal disease. Their hypothesis was that bypass would have superior long-term outcomes compared with endovascular treatment of femoropopliteal disease in patients with premature PAD. So they did this by performing a retrospective review of prospectively collected data by reviewing files in the Vascular Quality Initiative from 2003 to 2019. They identified all patients who underwent infrainguinal bypass and peripheral vascular interventions. They included only those patients who were less than 50 years old, had documented TASC C and D lesions, who underwent exclusively bypass versus endovascular treatment, and who had follow-up out to 1 year or had a registered death within 1 year. They excluded patients who underwent treatment for aneurysmal disease, acute limb ischemia, or who underwent a hybrid procedure or who had inadequate follow-up. So this data query left them with about 2,500 patients. Around 900 underwent endovascular revascularization, and about 1,600 underwent open bypass. The endovascular cohort had a higher proportion of females and unsurprisingly a higher rate of comorbidities, including CAD, CHF, and end-stage renal disease requiring dialysis. The endovascular cohort was more heavily skewed toward treatment of claudicants. 45% of the endovascular cohort was treated for claudication versus only 36% in the bypass group. The open cohort had higher rates of diabetes and smoking. They were more likely to have undergone previous revascularization surgeries, 59% versus 54% in the endo group. And they had lower starting ankle brachial indices, 0.56 in the open bypass group versus 0.69 in the endovascular group. So as seen on the previous slides, there were many significant differences in demographics and comorbidities between these two cohorts. These differences are likely what played into how surgeons selected what type of revascularization was performed on each patient. So in an effort to reduce the selection bias, propensity matching was performed where two cohorts were created with similar levels of covariables. They were matched for demographics like sex, race, and insurance, and for comorbidities such as BMI, hypertension, diabetes, history of previous revascularization, and current smoking status. They performed the propensity matching in an attempt to isolate the effect of the treatment modality on outcome and to separate it from the effects of other comorbidities and social determinants of health. So after propensity matching was performed, they created two cohorts from their original data. Each cohort had 466 patients. Between these two cohorts, there was no significant difference in diabetes, current smoking status, or dialysis. In comparing demographics and comorbidities, the only significant difference was open bypass patients had lower ankle brachial indices to start, 0.60 in the open group and 0.67 in the endovascular group. They also looked at procedure characteristics after propensity matching, which you can see in table 4 in the paper. They looked at endovascular location of treatment. 65% of interventions were performed on SFA lesions. 6.9% were popliteal only interventions, and 29% were combined SFA and popliteal interventions. There were 77.5% of patients who underwent treatment for task C lesions and 22.5% who underwent treatment for task D lesions. They were not able to directly compare the two groups because they did not have task classification data for the open bypass group. But they were able to tell us that 52.2% of patients underwent above the knee popliteal bypasses and 47.9% underwent below knee popliteal artery bypasses. So then they looked at differences in perioperative outcomes between the two groups. Although open bypass was associated with lower reintervention rates, they did have longer length of stay and higher perioperative complication rates. Here's a Kaplan-Meier curve showing that there was no significant difference in overall survival between the two groups at 1 year. Nor was there a difference in amputation-free survival, as can be seen on this Kaplan-Meier curve. There was, however, a difference in the reintervention rates at 1 year, with the endovascular group requiring higher rates of reintervention, 25.2% in the endovascular group and 17% in the open bypass group. Overall, I think this was a good look at an important topic for which we have limited data. Short of a randomized controlled trial, this is kind of what we have for this patient population. And I think it was definitely an interesting way to look at an important question. In terms of limitations of the study, like any database study, there are limitations associated with data availability in the BQI. For example, it doesn't allow us to obtain family history or genetic information, as they pointed out in the paper. Additionally, retrospective review of prospectively collected data does not allow us to control for selection bias. Ultimately, the choice as to what revascularization was performed was left to the discretion of the surgeon. The authors tried to compensate for this with their propensity matching. The follow-up duration at 1 year was also somewhat limited. Additionally, we don't have task classification or anatomy data on patients who underwent open bypass. We know that above the knee versus below the knee bypass ratio was about 50-50. And I think it's reasonable to assume that patients undergoing below the knee bypass had task D lesions, but only 29% of patients undergoing endovascular had popliteal involvement. And as pointed out by the authors, 58% of patients who underwent open bypass had previous lower extremity revascularization. And you could say that after propensity matching, a similar percentage of patients underwent previous revascularization in the endovascular cohort. However, I don't think you can necessarily say that previous revascularization in a patient who subsequently undergoes endovascular confers the same severity of disease as a patient who undergoes a primary intervention and then subsequently requires a bypass. In terms of future directions, the article mentioned looking further into cost efficacy, which I agree is important to take into account. And the outcome studied was need for revascularization, period. It would be interesting to look at frequency of revascularization and see if that differs between the two groups. I think this would circle back into the discussion on cost efficacy, but also it would play an important role in functional outcome and quality of life for our patients, which is ultimately our goal and what we care about. It would also be interesting to follow this data further to see if the outcomes diverge past a certain amount of time, especially in this group of young patients who could potentially have a longer lifespan. So in conclusion, I think this article gave a nice review of literature showing that patients with premature PAD have poor outcomes when it comes to need for revascularization and limb salvage. Their data show that both treatment modalities seem to be equally effective in terms of limb preservation and survival at the 1-year mark. Femoral popliteal bypass was associated with decreased rates of reintervention compared with endovascular therapy in patients with premature PAD. It's important to note that reintervention rates are high in both groups, even though it's higher in endovascular. These patients do worse than regular PAD patients. So it's important to always keep looking at ways to improve their care and their outcomes. And this is something we should take into consideration when treating patients with advanced disease and potentially long life expectancies. Thank you.
Okay, that was a great presentation of the article. So I'd like to say thank you to Katie for presenting that. And please put your questions in the chat. I'll be happy to bring them forward. But I do have a question for the authors. How do you anticipate this data changing our practice? In other words, should we favor one modality over the other? I think the point of it being only 1-year follow-up is really valid, although of course very difficult to get longer follow-up in this cohort. And so I'm left with not really knowing if this should change how I treat my patients.
Thank you for your question. And thank you, Dr. Swanson, for an excellent presentation. Yes, I think, this is a small, relatively small group of patients with PAD, and before this paper, it was all the information that we had was limited to case series, as presented by Dr. Sheehan, and we thought we will take a deeper dive by looking at the VQI and studying that patient population. To be honest, my hypothesis and my expectation was that even amputation rate will be lower, maybe with bypass, especially with vein bypass, knowing that, or maybe it's our bias that we think the vein bypass lasts longer and probably needs lesser interventions. And in our data, more than approximately 55%, I think, of the patient had a saphenous vein bypass, and yet the limb salvage rate at 1 year was very comparable between the two groups. And I agree with you, it's hard to tell. I mean, is it better to do a bypass and spend a week in the hospital, or do 2 outpatient procedures with a stent and a balloon maybe, and not even have to stay in the hospital? There's a lot of patient values, complex lesion characteristics, as well as cost effectiveness that's involved. And I think the message is I think both therapies for this group of patients are acceptable, and there are probably some individual factors that can be taken into consideration for each case separately.
Yeah, and I think, unfortunately, I think the key to the answer is honestly probably more than 1-year follow-up. If we knew what that outcome was comparatively, would be really helpful. In addition, there was another question I wanted to ask, and Peter Lawrence actually brought it up as well. I've always thought, and he says this, I've always thought that there was a much higher prevalence of hypercoagulability in these young patients with PAD, and that was always my impression as well. Did you look at this at all, and was it matched for?
I don't think the VQI captures hypercoagulable states per se. But there's we did capture medications, and it did not look like there was differences in pre-op medications between the two groups that we compared. But that is a very important question, and I think some of the case series that were published show that up to 30% of those patients have documented blood serologically proven hypercoagulable states, which is significantly higher than the average patients of PAD that we see.
Dr. Bechara brought up a good point about young patients, especially women having small vessels. Here in New Orleans, we see this a lot with aortoiliac occlusive disease, so we tend to do more aortoiliac endarterectomies on them because their vessels are much smaller. Do you think that's what drove the higher percentage of endovascular procedures in females?
Yeah, it is possible.
And then there's several comments about medical therapy. So Paul brought up, for claudication, do you think medical therapy would have worse outcomes as well for this patient population, or should we simply stay conservative and treat them medically?
I think one of the other interesting points of this paper, and something we've looked at in other papers looking at premature PAD, is that in the VQI, at least, rates of medical therapy are pretty low among this patient population. I think only 70 or 80% were on an aspirin and a statin. So I do think that's an important point that we could probably be better at.
And was there differentiation between symptomatology? In other words, was there differentiation between claudicators versus limb threatening?
Tanner, you want to take that one?
Sure.
The master of the data.
In this particular study, we did not parse out differences. I mean, although we did a propensity match, we didn't separate analyses based on claudication or CLTI. But I do think it's a valid point.
Yeah, Dr. Stone. Oh, go ahead.
Go
Go
ahead. Dr. Glavitsky was asking about Berger's disease. I don't know that the VQI identifies that. Is that part of the?
No, it's not available.
Okay.
And what I wanted to say is we're in another study that also Tanner has published in the JVS. We looked at the impact of age and the extreme of age in patients with CLTI only. And and we have a very nice graph actually in that paper, and you can see that if you take decades of age, starting with patients from that are younger than 50, and you go by 60s, septuagenarian, octogenarian, nonagenarian, you can see that the rate of amputation just goes down from 7% to 5%, and that was a work that Tanner actually did, and he kind of spliced those into 5 to 10 years age group, and you can see there's a straight kind of very nice, almost like a dose response curve, where you see that with increasing age, if you take all the patients that present with CLTI, regardless of how you treat them, as a population health, the risk of amputation kind of slowly goes down with time. And clearly the premature patients with PAD have the highest risk of amputation, perioperatively as well as at 1 year.
So is the age of 50, is that where we should kind of start to consider them different? That's what, because we used to say 40, now we say 50, now 55.
So I use 50 because one of the publications actually that I did in my fellowship when I was a fellow at UPMC was looking at the cutoff point, and we looked at approximately 300 patients with premature PAD with PAD at the age of less than 50, 50 to 60, and then 60 to 70. And we found that when you look at the patients who are older than 50, they probably look a little bit more homogeneous than the patients that are less than 50 with respect to patency of endovascular procedures. And we found a difference in amputation rates back then. And of course, it's a gradation. I mean, it's not like a black and white and clear, demarcation. But I think for the sake of simplicity, I think 50 sounds like a good cutoff. And we have actually, Tanner will be presenting an abstract at VES and skiing in January. looking at basically the overall distribution of patients who present with PAD, and you can see that the 2 standard deviation cutoff comes kind of at the age of 50, and those patients have really different characteristics than the patients who present at the usual age of like 75 approximately.
Yeah, it makes sense that the younger the patients, the younger they are as they present, the higher the likelihood in their lifetime of reaching amputation, because we run out of options. So Dr. Stoner had brought up the point that a large proportion of the bypass group had prior endovascular procedures. And the question is, are these people just worse off than those who just simply had primary bypass? In other words, more aggressive disease.
I mean, I think that's probably a fair point. They probably are. They probably just have, for whatever reason, more aggressive disease. And I think studies have previously shown that patients who undergo bypass after endovascular procedures do a bit worse.
Yeah, I think that's probably true. So I would say that we're just about at time. I think we have. I think we've covered all the questions that are in here, other than Dr. Weston, who had brought up a point earlier about the medical therapy, did let us know that the VQI is rolling out the module for medical therapy. So while we can't answer the medical therapy question now, hopefully in the future, we'll be able to do so.
Absolutely. Thank you very much for discussing our paper. We're just honored to be here on that journal club.
Thank you.
Well, thank you. And thank you for Dr. Brown for moderating. We're going to transition to our next paper, and we'll have Dr. Abai introduce that and introduce the topic.
Thank you, Misty. I'm going to give a crash course and just tell a little bit of story. I'll let Dr. Mufid present do the heavy lifting and present the data, and I'm going to miss a lot of stuff because this is a crash course, really. But it's a story about fenestrations and branches. In 1987, Nikolai Volodos put the first endograft in the thoracic aorta of a post-traumatic patient. Around the same time, Juan Parodi put the first endograft in 1990 in Argentina. Now, these were simple grafts that were tubes, and we know that the aorta has a lot of branches, and arguably, you can cover and sacrifice certain branches. I know some of them are controversial, for example, the left subclavian, and you have to really preserve certain other branches. So in order for us to be able to treat these patients endovascular, we had to come up with ways of essentially not covering these branches. The first major branch that you can't cover is the common iliac artery. Otherwise, you have to do a fem-fem bypass. And Tim Schroeder in 1993 essentially deployed this first graft in a patient, and there's a bifurcated graft so that you wouldn't cover the common iliac artery, and there would be flow to both extremities. In the US, we have very limited access to these branches and fenestrations. In 2012, the FDA approved the Cook-Zenas fenestrated graft that allows for 2 fenestrations and 1 scallop. The main disadvantage is that there's a 6-week lag in making these grafts. This was followed in 2016 by the IVE device by Gore that addresses aneurysms in the common iliac artery. And it's arguable that whether you can just embolize and cover it or not. We know from Veets data that maybe you can embolize both hypogastrics, and you don't have to do that. Of course, people have been inventive, and there are people who have put chimneys in order to address some of these issues. But here mainly we're working on, we're talking about fenestrations and side branches. So going back, Shooter, the device on the left is Tim Shooter's device. The middle one is Greenberg's modification. The right one is the T-branch device by Cook. Essentially, these are designed to address the problems of covering the renals and viscerals, which could be deadly, or at least would put patients on dialysis in some cases. These devices are unfortunately not available commercially in the US, but some of our colleagues in other countries and some of our other colleagues who have IDEs can use these devices and have them custom made. These even have sometimes longer lag times when they're custom made. Of course, there is also thoracic branch devices that are being developed and tested out there. And these are an array of them. One of the major problems with these is their high stroke rate. If you don't have access to these devices, you can always do what we did. This is one of our first cases that we did at Jefferson with the physician-modified endografts. This is a Cook device that was modified to have a celiac and a SMA fenestration for a patient who has renal failure. And it was sheathed and it was placed successfully. So, okay, we have these fancy grafts and we can, either order them or do some back table work to create them. So how well do they do in real life? And I think this is what our Italian colleagues have tried to show in this Italian multi-center fenestrated and branched registry. I'm going to turn it over to Dr. Mufid, who will present their data. Thank you.
Okay. Thank you, Dr. Obai. Good evening, everyone, and a good morning to our colleagues from Italy. My name is Ali Moffat, and I'm one of the vascular fellows at Thomas Jefferson University Hospital. Firstly, I'd like to thank you all for giving me the opportunity to present this interesting paper. And I would like to congratulate the authors as well for such a well-executed project. So just to give a quick background on the objective of this paper, complex juxtarenal and pararenal aneurysms, as well as thoracoabdominal aneurysms, are more frequently being treated with branched and fenestrated EVAR procedures. However, due to the difficulty and complexity of these endovascular approaches, most outcome reports came from single, highly specialized centers. So the objective of this paper was to report a national multi-center experience and to evaluate the predictors of early and midterm outcomes in large populations. So this was a multi-center observational study of patients undergoing fenestrated or branched EVAR, recorded prospectively between 2008 and 2016 at 4 Italian academic hospitals. Preoperative comorbidities and post-op complications were classified consistent with SVS reporting standards, and the data was analyzed retrospectively. The fenestrated or branched EVAR was offered, if anatomically appropriate, to individuals at high risk for open repair, such as previous aortic surgeries, SVS score of over 10, COPD, or coronary artery disease SVS score of over 2, and ASA score of 4. The primary study endpoints were divided into early and follow-up outcomes. Early outcomes were 30-day in-house mortality and spinal cord ischemia. Survival, freedom from reintervention, and target visceral vessel patency were assessed as follow-up outcomes. Risk factors for spinal cord ischemia, 30-day in-house mortality, follow-up mortality, and reinterventions were also analyzed. Prior to discharge, all patients underwent lab evaluation of renal, hepatic, and pancreatic function. They also underwent a CTA within 30 days of the procedure. The follow-up program was per protocol of each center by clinical exam, radiographs, Doppler ultrasound examination, or contrast enhanced ultrasound plus minus CTA at 6, 12, 18, and 24 months, and yearly thereafter. In terms of analysis, survival, freedom from reintervention, and target visceral vessel patency were estimated by the Kaplan-Meier method. Risk factors for 30-day in-house mortality and spinal cord ischemia were determined by multivariate analysis. Risk factors for follow-up mortality and reinterventions were evaluated by Cox regression model. 596 patients underwent fenestrated or branched EVAR for complex aneurysms in the 4 institutions. 508 patients were male. The mean age was 73 with a standard deviation of 7 years. The mean aneurysm diameter was 62 with a standard deviation of 6 millimeters. In terms of anatomic features, 124 of the aneurysms were juxtarenal, 121 were pararenal, 351 were thoracoabdominal, and of the thoracoabdominal aneurysms, 263 were types 1, 2, and 3, and 88 were type 4. 520 patients underwent elective repair, and 76 patients underwent emergent repair, either due to contained rupture or a diameter of over 80 millimeters. With regards to early results, technical success was achieved in 557 of the cases. Of the 39 cases with technical failure, 15 patients had early reintervention and 10 cases were due to 30-day in-house mortality. 41 patients had cardiac complications, 50 patients had pulmonary complications, 80 patients had renal complications, of which 8 patients remained on permanent dialysis. There were 7 cases of bowel ischemia, 23 patients had cerebrovascular complications, and 47 patients suffered from spinal cord ischemia with permanent paraplegia in 17 cases. Crawford's type 1, 2, and 3 thoracoabdominal anatomy and postoperative renal complications independently predicted spinal cord ischemia. Overall, 32 patients died within 30 days post-op. Preoperative chronic kidney disease, post-op bowel ischemia, cardiac complications, cerebrovascular complications, and spinal cord ischemia were independently associated with 30-day in-house mortality. In terms of follow-up results, the mean follow-up was 25 plus minus 7 months. Freedom from target visceral vessel occlusion was 96% at 1 year, 93% at 3 and 5 years. Freedom from target visceral vessel occlusion was higher in patients with juxta and pararenal aneurysms than with thoracoabdominal aneurysms. Overall, 93 patients required at least 1 reintervention, with 23 patients requiring multiple interventions for a total of 127 reinterventions. Freedom from reintervention was observed in 92% at 1 year, 85% at 3 years, and 79% at 5 years, respectively. Freedom from reintervention was higher in patients with juxtarenal or pararenal aneurysms versus thoracoabdominal aneurysms. Risk factors for reintervention were thoracoabdominal anatomy, post-dissection thoracoabdominal aneurysms, and post-op bowel ischemia. Survival was 88%, 78%, and 69% at 1, 3, and 5 years, respectively, and survival in patients with juxta and pararenal aneurysms was higher than in patients with thoracoabdominal anatomy. In terms of mortality, preoperative chronic kidney disease, urgent repair, thoracoabdominal aneurysms, and post-op intestinal ischemia, and cardiopulmonary complications were independent predictors of mortality during follow-up. So this study was very well executed with remarkable findings, but there were a few limitations. Firstly, despite prospective data collection, the analysis was done retrospectively, which can create potential for errors. The procedures were done at 4 academic centers across Italy, each with 3 or 4 surgeons over a steady period of 12 years, which can potentially introduce variability in technique. The fenestrated and branched EVAR program did not start at the same time in the 4 institutions, which could have potentially caused variability in the learning curve of the surgeons. And this also highlights the importance of surgeon expertise in treatment of such complex aneurysms. And lastly, the follow-up is limited to early and midterm results, though we should keep in mind that due to the relative novelty of these techniques, there's currently no long-term data in literature. So the authors concluded that fenestrated and branched EVAR technique is associated with satisfactory early and midterm outcomes in a nationwide multi-center experience. This is important because it highlights that this technique can be applicable to a real-world experience outside of highly specialized centers. While the data was very promising from this paper, long-term data is still needed to confirm early and midterm findings. And with that, I would like to thank you all for your time and congratulate the authors again.
All right, very good. So thank you very much for the presentation. I congratulate the authors as well in their multi-center paper. And I'm going to start the discussion with a question that's rather obvious looking at the data, which is, again, what we see as in every other vascular study I can think of. Chronic renal failure is a marker of bad outcome. Interestingly, it's not a marker of technical success in this paper or need for reintervention, but it is a marker for bad outcome, complications, and mortality. Do the authors think that this influence of renal failure, which is quite strong, especially in the mortality side of things, should affect the selection of patients for this operation? In other words, should the size threshold change for patients with renal failure?
Thank you for the question. Thank you for the good presentation of the paper. It's clear that renal function is one of the main risk factor for all our patients in all the vascular surgeon. The question is the answer is yes. In these patients, maybe the chronic renal failure is only the factor that preoperatively can select these patients, but it can be not the only one. Depends from the size of the aneurysm, depends of other comorbidity, the age, but it is one of the most important factors that we have to evaluate in the selection of our patients. This is one of the main conclusions of the paper.
Can I add something, Enrico, if you don't mind? Obviously, what you said is perfectly right, but also we have to consider that many of our patients were submitted to surgery for an emergent reason. So I think the question is very clear, but sometimes you don't have even the time for assessing carefully and taking care of the renal function. You have just to go ahead because the patient has a symptomatic thoracoabdominal aneurysm and you have to treat it anyway. And that point, you know, the survival and freedom for intervention is lower, but what can you do?
Yeah, no, I think it's an excellent point, right? And I think it's completely different to look at a risk reduction operation versus an urgent operation, or completely different calculus. A couple of questions that come up in the chat, and I have a similar question. Were there, inside the data, were there particular bridging stent constructs, fenestrated constructs that were related with branch patency? And obviously we see that branch patency and mesenteric ischemia are devastating complications. And I realized it was more common than the TAA group to have loss of patency of the branches. But did you guys realize in this data set any particular problems with branches or certain stents or certain constructs?
Thank you again for the question. As we can observe, the patency of target visceral vessel was lower in thoracoabdominal aneurysm. Yes, one of the main risk factors for the lower patency in target visceral vessel is the branch design, especially for renal artery. Moreover, thoracoabdominal aneurysm have a higher diameter at the level of target visceral vessel, so we have any problem in target visceral vessel instability. We have no dedicated bridging stent for this design. So yes, one of the Achilles of this technology is the branch design for renal artery. So we have to try to plan fenestration as much as possible in renal artery, and when it's not possible, we have to follow patients with branch in renal artery with a strict follow-up protocol.
And did you have a protocol for the intervention should an endoleak arise around the branch, and how do you deal with those?
The protocol of follow-up for this endoleak?
No, if an endoleak occurs, like a branch endoleak, a 1C endoleak occurs.
Yes, in case of detection of endoleak, 1C endoleak, we perform the CT for the detection, and then we try to perform a selective angiography to detect any defect and correct it.
If I can add something regarding the problem of fenestration and branching, we have a couple of papers already published last year on JVS about this matter, assessing what Enrico has just said about the impact of fenestration and branch stent graft in this kind of procedure.
Along the line of the branches as well, Peter Kavitsky notes that 18% of the patients in the Mayo series had intraoperative problems related to the branch, especially the women or smaller branches. Do you guys in your large series see target vessel sizes that you will just abandon, or the renal sizes that are very prone in your experience to these problems?
I'm sorry, but maybe I don't understand about the size of the renal artery.
Size of the renal artery, and
yes.
which size are you going to have branch problems in your series?
Okay, in this dedicated series, we have not considered the anatomical morphology in terms of size, of diameter, length, and angulation of renal artery. This is a multi-center registry, so we have not a lot of data in this setting. We previously published an experience about the anatomy of renal artery in this technology. We evaluate that the orientation of renal artery is one of the risk factors for the loss of patency, but no the diameter of the artery, of the length of the branch. In literature, there are a lot of papers that underline this problem. Maybe one of the key factors for the renal patency is the diameter. Renal are lower than superior mesenteric artery and celiac trunk, but maybe these are also the arteries that have different angulation and mobility in comparison with superior mesenteric artery, celiac trunk. So probably it's a multifactorial aspects that reduce the patency of this artery.
And no, I think you're right. We worry whenever we're starting to look at 4mm renal arteries and how we're going to build a fenestration plan for cases like that, or a snorkel plan or anything. Now, I guess you touched on this in the paper as well. do the centers standardize their use of advanced imaging technology to bring in Paul and Carlos's questions? Do you use standard methodology for pre-op CT scan workup? Do you use anything intraoperative such as fiber optic catheters like Forest technology or anything like that? And then intra-op, do you use cone CT to look at the branches at the end of the case?
Yes. Again, this is a multi-center registry, so the 4 centers have different approach in the procedural time, so we can have some difference, but in the most of cases, this procedure were performed in the hybrid room, so with all the adjuncts of the that we can perform. So we usually adopt the fusion imaging during the procedure with the possibility to use the CO2 angiography to reduce the amount of iodinated contrast media, and finally the combined CT to check potential defects that are not visible in the final angiography. So this combination of different tools could increase the technical success and the midterm clinical outcome. So this is a message that yes, this is a real life registry, but is an experience performed by 4 dedicated centers with high volume in this technology. I think this is one of the key message of the registry.
Yeah, I think that makes some of the questions that were being asked are difficult to answer because of the nature of the registry. But I think this brings in Peter Lawrence's question just now, because I think the strength of the paper is the fact that you carry this out in a multi-center registry with excellent results, excellent branch patency, well done analysis. Do you feel that there are minimum volume of cases annually that a surgeon should perform to do these complex aneurysms, both simple aneurysms and complex aneurysms? So what did you learn from your experience at these 4 centers?
Okay, for definition, the centers that are involved in the registry have to be performed at least 20 cases of advanced technology in endovascular aortic repair. So at least 20 cases per year of fenestrated branch endograft for complex aneurysm. It's clear that this team are performed by performed with surgeons that have a high volume of aneurysm case per year in terms of standard EVAR, in terms of standard thoracic aneurysm repair, and also for fever and beaver. So the learning curve of the operator that are 3 in each center, it's required.
To answer more specifically to Peter Lawrence's questions, in Italy, overall Italy, there is not the same organization that you have in the US. So you don't need to have privilege for your hospital to get this kind of procedure done. So as Enrico said, the registry was limited to high experience centers, but overall in Italy, there is now a strict regulation about who can do what.
And I guess the last question, we're just about at the top of the hour, that I'll ask, again, you may not have this information in the registry, but about directionality of branches, did you find that in cases, I'll read a bit into Tom Forbes's question, did you find that supradiaphragmatic, like upper extremity or axillary axis, is more prone to cerebrovascular events or stroke? And did you change any of that over time?
Maybe Enrico lost the connection. I don't see.
He's talking, but I don't hear him.
I can answer the question. No problem. Actually, yeah. Usually we have a double access from below and from above. And we try to not to get into the right subclavian, but preferably on the left side, and this in order to minimize problem in the arch. However, obviously, every case is different from the other, so we don't have a strict protocol of about going from above or below, but we choose the best option for technical reason usually. But yeah, as I said, we try to avoid the right harm for getting in the arch.
All right, well, I guess I'll just say again, congratulations on the paper and congratulations to the group from Jefferson for discussing the paper. I appreciate the opportunity.
I want to thank everybody. I think we had so much great conversation with both papers this evening. It's really fun to have the authors because they can give us the nuances behind the work. It helps stimulate so much great conversation. We will be reaching out on social media on SBS Connect about January's date, so please look for that. We also do send an email to the program directors, and we'll try to get that out early for everyone. Thank you all for being here this evening, and we'll see you in January. Happy holidays.
Merry Christmas. Thank you for
Thank you,
inviting
guys.
us.
Thank you. Thank you.
Merry
very much.
Christmas.
Merry Christmas.
Arrivederci.
Ciao, Paul.
Ciao, ciao.
Ciao. Ciao, Peter. Hi, Peter. Merry Christmas to your family.